How do we make this disappear?
More. Hide, hide floating meeting controls. Third one from the bottom. Yep, no. But don't worry about it. Cut it.
Welcome to the inaugural episode of 5, 10, 15 Journal Club. 5 minutes to convene, 10 minutes to present, and 15 minutes to discuss. My name is Sean Dunn. I'm with University of Arizona School of Health Solutions in Phoenix. I'm a graduate student in clinical translational science. And I'm here with my colleague. I'll let him introduce himself.
Hi, my name is Nabhan. I'm a CTS PhD student at the Center for Applied Nanobioscience and Medicine at the College of Medicine, Phoenix. And welcome to the inaugural session of the Journal Club.
So as the name lays out, we're going to take 5 minutes to convene. This is just a time to discuss, and it's 2025. It's our first week back from vacation. I have high hopes for 2025. I'm going to try and read wider. I'm going to try and work smarter in the lab. And I'm also pursuing things outside of graduate school. I joined a run club. I'm working on my fitness. I've been trying to go to the gym more regularly. I've been attending church to pursue my spiritual growth. And so, yeah, I've got a lot going on right now.
Super cool, John. Yeah, I think similar 2025, I feel, will be quite the year, given the developments I think that we've had in the last few years, and as well as the fact that we've just come out of a pandemic and we are a few years after it. And I think we understand quite a bit now differently and look at things differently compared to how we looked at health and looking at different solutions in terms of vaccines. And I think research in medicine overall has been reshaped from what we saw during the pandemic. And I think 2025, again, I think I similar to what you said, want to pursue and read more. I think reading is being put on top as a higher priority to me right now. And then I think the goal for this year will be to progress on my project itself, and among other avenues outside, I think develop on various different skills, including new coding language and a few other similar avenues.
More coding, more computer. I think we all need to go that route as well. Like going into the future, everything's going to be more digital, more program-based. It'll give us accountability and also efficiency. And so I think if we don't cultivate those aspects of our career, we're going to get left behind. So that's good that you're doing that. I also need to dig deeper into coding. Yeah, are you reading anything besides science right now?
Nothing besides science as of the moment. I think my last read was the classical The Monk Who Sold His Ferrari. The next read that's coming up would be I forget the name of the author, but it's the CTS PhD book.
Oh yeah. He gave a seminar here. I'm rereading that right now too.
Yeah, I need to start reading that. I'm yet to even open the preface of that book and start, but I think it's from a fellow colleague at the center, AJ. I think it seems to be quite the eventful book for him, and he's learned a lot through it. So I hope to go through that book as well and try to gain insights from that author.
Yeah. It's eye-opening. You can't just get a PhD and expect to be successful. Like I know a lot of people with PhDs who are doing the same work that people with undergraduate degrees are doing. So it is what you make of it. And it's important to have goals, know where you're going and how to do it, or else you're not going to be successful.
I agree, Sean. And on that note, I think a few other things that I think this year would be key for me at least is to, I think, improve on my soft skills, primarily I think communication, because one specific aspect I've heard from a lot of PhD students, especially in health sciences, I think we get uh, too involved within our research and our labs, and we end up forgetting how to communicate that science out effectively to in general terms that's understandable by all. So I think one of the key goals this year for me is also to improve on my communication and communicating science as a whole. And I think for us both, this journal club, I think, is one such way we hope to improve.
Yeah, and part of, in my opinion, part of science communication is playing towards the effective domain of people, how much they care. You can't make people care. And science is complicated. So if somebody doesn't care, we need to be able to communicate it in a short amount of time. You can't just talk. You have to make it like people communicate in memes now. We need to make it simple enough where you can grab their attention for 30 seconds. So
I
that,
agree, Sean. And on that note, I think we'll move towards the second avenue of the 5, 10, 15 journal club, which is the 10 minutes of presentation time. And for today's first session, I'd like to introduce Sean. And Sean will be presenting the transplantation of chemically induced PSC-derived islets and abdominal anterior rectus sheath in type 1 diabetes patients. And it's a paper that came out this year in Cell Press, and I'll let Sean take it away.
yeah, thank you for reading the title. So this is a report. It's a 1-year report on a patient who was the first to get a allogenic chemically induced pluripotent stem cell transplantation for curative purposes of type 1 diabetes. This is somebody who had uncontrollable diabetes, received a liver transplant, and also a pancreas transplant. And their particular blood type made them a poor recipient of transplants, and they had to actually have their pancreas removed because their immune system rejected it. So this person, they weren't able to control their diabetes with insulin injection, and so one of their options was this research-based transplantation. And let's go ahead and walk through it. I think that this is going to be a seminal paper in the history of medicine. I think that we're going to be talking about this particular paper for the next 50 years. I think it's going to change the way that we practice regenerative medicine and medicine in general. So let me see how we move forward here. Sorry, this is our first time. Okay. All right, chemically induced pluripotent stem cells. Pluripotent stem cells were, the first publication came out in 2007. They did it by using transcription factors where you do viral vector to increase certain genes to revert them back to embryonic-like states of stem cells. They target different transcription factors like OCK4, SOX2, KF4, and CMYC gene. CMYC gene in particular is an oncogene, and there is a lot of controversy in the field about induced pluripotent stem cells not really being true representations of matured cells. It's more like a cancer cell than it is actually an organ. So this particular group that we're talking about that did this publication has spent the last decade working on a different method of reprogramming called chemically induced pluripotent stem cells, where instead of using transcription factors, they use synthetic compounds to target signal transduction pathways within the cells to revert them back to pluripotent stem cells. And they make the argument that this is a better system for the end goal of transplantation because there's less chance of tumor development, tumorigicity. So here I show figure 1. This group, they collected adipose tissue, fat tissue from the patient. They reprogrammed them in this chemical manner, which there's publications all on exactly how that works, but it's different than transcription than the traditional method. And then after reprogramming them, they mature them into insulin production cells, the islet cells of the pancreas that helps to control glucose production in the body. So they go through those steps. They cryopreserved them, and then pre-transplantation, about 3 days before transplantation, they resurrected these cells. And then they do this ultrasound guided injection of these islet cells into the what do they call this? The subanterior rectus sheath, which is basically just right underneath the skin of the abdomen next to the muscles that make up your abdominal muscles, your six-pack. So instead of putting it right on the liver and the pancreas, they put it in this region, and they state that they did studies with with primate models, and they showed that this was the best location where they stayed in the same position, in the same shape, and were not disrupted. And they also received vascularization, and they had the best insulin production. Okay. Okay, so just a little bit about this patient. They were diagnosed with type 1 diabetes as a child. They received a liver transplant. So this person is very sick. They're on immune suppression. Their type 1 diabetes was uncontrollable with insulin, so they were a candidate for pancreas transplantation. They received that. And they had to have the pancreas removed because they were positive for the panel of reactive antibodies. They were reactive to HLA-1 and HLA-2, which just makes them a poor candidate for transplantation in general. And so this new method, this research study was brought up as an option, a mercy option for this patient to get a new to receive islet insulin production cells by pluripotent stem cells. So they received this. Research study. It's a phase 1 clinical trial, autologous transplant, and let's walk through the year 1 follow-up. So to cut the story short, they at year 1 follow-up, they successfully came off of insulin. Their transplantation is making levels of insulin comparable to a healthy individual. At day 75, they became insulin independent, as shown in the top figure. And then their fasting glucose came into normal levels. So without any medical intervention, they're completely working off of this transplantation. The number of days where, the percentage of days where they were in good glycemic range, healthy range, was greater than 95% at month 4, which is fantastic. So at year 1, we can say, this patient is healthy. They're cured. We cured diabetes. We cured type 1 diabetes with a transplant of stem cells. It's the first time this has been done. and it's quite revolutionary. And they don't, you know, this patient's already has a liver transplant as well, so they're already on immune suppression, but this transplant was allogenic. It was from them, so it'll be interesting to see what happens when somebody gets this transplant without immune suppression. So one major concern about transplantation of stem cells is the production of or of it turning into a tumor, becoming tumor genic. So that was one of the major reasons why they chose to do the chemically induced pluripotent stem cells as compared to the traditional transcription factor overexpression. So here they just show imaging with ultrasound and MRI, where they show that this transplant stayed in the same location. It didn't have any major fat accumulation or irregular shape as would be present if it did start to become hematomic and or start to turn into a tumor. So at 1 year, it stayed in location and it's doing great. And it didn't really make sense to me at the time when I was reading it why they would put it in that location. But they made the argument that it will interact with the body's circulation less. It'll be less interrupted. It won't be pushed around. It's a stable location, and it can still communicate with the body and produce the insulin as needed. And it gets vascularized. Okay, so I wanted to make it short and simple. That was the basic overview of this paper. We still have 5 minutes left in the presentation. So just to talk a little bit more on this, they did a lot of QC studies to show that that they were transplanting what they expected to transplant. So they wanted to make sure that all of the transplanted cells were differentiated into the islet cells or islet-like cells. They didn't want to put in stem cells because these pluripotent stem cells, if transplanted at that range, could differentiate into any type of cell, and that increases the risk of causing tumor development. And that's one of the major things that is of concern when getting a transplant with stem cells is we don't want to give the patient cancer from this. So they spent a lot of time with PCR and flow to show that every single cell in that transplant was in fact differentiated into the intended cell type. And then they also did genomic analysis, whole genome sequencing to show that there is no presence of cancer, oncogenic cancer genes activated. So they spent quite a bit of time with QC, which I think is essential when dealing with patients like this, especially in a phase 1 clinical trial. This is the first time this was done. It was done in the People's Republic of China, which is fantastic. I'm very impressed with this group. And they make the argument that we really need to continue to do studies like this, that this could really change the way that we do medicine. So with that, I'm going to go ahead and cut the presentation short by a couple minutes, and let's go ahead and discuss and just get your thoughts. So, yeah, what do you think, Naban?
Excellent paper, Sean. I was just looking at some of the T2 weighted fat suppressed images and all of the images that are presented in the paper. And I think this is my comments in no means are critiquing the research itself, but more so the data presented in the paper. I think it's just my opinion about the data and not something that's a fact, but I feel like the T1, T2 weighted fat suppressed images that are present, I think while their discussion generalizes excuse me, while their discussion generalizes the fact that there is no, there's not significant fat production around this region, i.e. indicating tumorigenicity, I think there is still a need to showcase the native fat production around this specific implant, is how I choose to address it. I think that would present a baseline on the amount of fat that's present across such implants that are done. Second, I think, and this is more so a general question that I have and a statement. While for pancreatic tissue, this seems like a viable method, and in this paper's context, I think one with regard to the same tissue over a period of time, as more and more trials develop, there are going to be certain variations between individuals that we see, and I think there is a need to identify those variations and try to identify them right now in terms of this patient so that they can be tracked over a period of multiple patient trials so that we could look at that variation and how that variation translates to in terms of its cause and effect. Now, I think the other part that I wanted to ask was more so from a medically relevant perspective. Now, within research, there are a lot of things that we identify that we look at as potential concerns, but there is a need to see how much of that holds medical relevance and actual physiological relevance to address, because not everything that we see needs to be addressed in many cases.
That was a lot of questions. So I know when I do like journal club, I hate it when somebody gives me a bunch of questions that I have to remember. I think, yeah, we should just go one question at a time. Can we talk more about that first one about the need for fat production? What does that mean? What do you mean by that?
No, I didn't say need for fat production, but rather the need for the native images where the fat is not suppressed and shown within the weighted images presented in the paper, so that we can characterize what's the fat production within these tissues as of this experiment. And that way we can compare that to, let's say, a patient who was being diagnosed for said tumor in a similar location and compare the two to ensure that that trend is not seen in this particular study. And also that would also allow us to compare fat production within such implants, indicating one of the criteria for tumorigenicity over a period of multiple patient trials that happen for this specific case study.
Right. Yeah, and neither of us are physiologist specialists, so I understand that. But let me just read this from the paper. What does it say? The T2 weighted fat suppressed imaging facilitates visualization of any morphological changes at the transplantation site, the left rectus abdominis. T2WFS images taken on day 28 post-transplantation revealed patchy, small, nodular, high signal areas at the left rectus abdominis compared to the images obtained before transplantation, indicating the location of the transplanted chemically induced pluripotent stem cell islet grafts. Subsequently, these T2WFS images taken over the following 365 days after transplantation showed that the signal on the grafts remained consistent and stable in terms of location, shape, size, and magnetic resonance signal intensity. And the left abdominis rectus exhibited no signs of compression, displacement, or deformation, which together showed no indication of abnormal growth. The image was used to detect abnormalities such as abnormal fat accumulation, which is a feature of teratoma. In this patient, the transplantation area exhibited signal intensities comparable to the surrounding normal muscle tissue isosignal, indicating the absence of abnormal fat accumulation. So I don't know what I'm not a specialist. I don't know exactly what that means, but I'll take them for their word that they were considering the fat accumulation. That's something that they were watching for. I had to look up that word teratoma. It's basically a collection of multiple different cell types, so bone, hair, fat, muscle. And that's something that they were particularly watching out for. They were very concerned that these previously pluripotent stem cells would turn into a tumor. And they were able to say, no, that's not what happened.
I think that answers my question, Sean. I mean, I would definitely still want to go into the supplement of this specific paper, which I haven't read as of right now, but I think to look at their supplementary data to hopefully see what additionally they do present. And I think generate my own inference of their results and try to compare with what they have presented, because I have observed in the past few papers, past few papers that I have read, that while the researchers presented a lot of data, when I went into their supplements and I looked at some of the data that was present there, had that data been included as a part of their work, that would have either, excuse me, either barely supported their hypothesis and or actually negated what they were trying to prove. But I think in most cases,
so what do you want to see? Like a biopsy or like a punch biopsy?
well, not just a punch biopsy, but more so, I think the non-fat suppressed images, because I presume, and again, as Sean mentioned, neither of us are physiologists, and when I hear fat suppressed images, and after what Sean read out from the paper, I think my inference of that specific image is that the native fat is being suppressed, but not the additional fat that would have been produced if it would be a teratoma, i.e., if there was fat production in case of a teratoma, that would have been showed in these T2 and T1 weighted MRIs that are present here.
Right.
And I think while I will probably go back and look at what does a T2 weighted fat suppressed MRI convey as from a physiological standpoint, I think I do still would like to see those non-processed images, which would allow me to create my own inference much better.
And the devil is in the details. You're right about that, Naban. We kind of just, I read that and I took it at face value, but you're right. There might be more there. I agree. We should look a little bit deeper into that. Okay, so you made a second point, variations to identify the variations of the patient. What do you mean by that? Like,
so I think what I meant by that, Sean, was I think in research we tend to take a lot of things and tests for granted. Like most of science today has been standardized to revolve around certain set techniques that exist, and we tend to
one type of mouse, the black 6-5 mouse.
The black that mouse, and then also the way we approach and analyze different parameters, right? We use fluorescence-based imaging and things along those nature. I think we sort of resort to defining our studies based on available techniques and instruments around us.
Yeah.
But I feel with certain revolutionary papers like this one you've presented today, that hopefully will be a revolution as maybe the year 2 results come out of this specific patient, and hopefully by then we have more patients who join the cohort.
Yeah.
I think the one critical need I feel in science that exists today is we go beyond what is available to us and start defining studies based on the actual parameters we want to look at, and then either create instrumentation or adapt instrumentation to support our need to identify those parameters. So
can you give me an example? Can you give me an example?
Yes. So what I mean as one of the, if I had to define it in one way, it would be, let's say I'm trying to look at the fluorescence of a said marker. Now, let's say that is located about 200 microns within organoid, right? Conventionally, the way this would be done is you use Z-slicing to go up to the slice resolution of the microscope and probe for that specific marker. Now, let's say what you're trying to probe for is actually located about 250 microns into the organoid. In that case, a Z-slice scope would not be able to go into that depth, reason being it's not resolved to go to that depth. And the next best way is to actually squish the organoid and thereby then image it. Yeah. Now, I think that's probably a very specific use case I'm giving, where you would maybe want to create an instrumentation that you could maybe inject, like probing into the organoid to try to image the native state of that probe you are trying to look at rather than actually squish it, because then you start assuming a few factors that the probe that's attached to your target remains the same way it would be when it's in the native state, for example.
Yeah.
And I think the other part I meant by saying identify the targets, I think one part of science is we try to start defining things by the current standards, but for cutting edge technology like this, I think there is a need to define what is the standard. Otherwise, it ends up becoming a kitchen recipe book, which becomes different in each lab, i.e. there is a lack of standardization. So as a group that first did it, I think from their end, it's one almost an unsaid responsibility that they define that, let's say, and this is just example, and these are not specific to this study, but I would say, let's define footprint A, B, C, D, E. And these are the specific A, B, C, D, E that we'll probe for in this patient at different time points, maybe, and then probe for in the next set of patients who join this cohort of study, and thereby analyze how that footprint A, B, C, D changes over these multiple patients and changes over a period of time, maybe revealing certain characteristics that would otherwise not surface if they were to be analyzed individually.
Yeah, I think diabetes is pretty straightforward. You know, it's a lot of people are affected by it. Glucose and several other targets that were mentioned in the paper are very well defined. Most primary care doctors all do the same thing. So I think this was a great target to do for the first time presenting an autologous transplantation. And even just the islet itself, you know, like this organ, the liver is a self-regenerating organ. It's already kind of primed to do this type of work. So I've been personally saying for years, that this was going to be the first organ that they did it with. Just because it makes sense. What the interesting part is with regard to variations, kind of what Naban was talking about, and coming up with standards and even medical relevance, which we're going to hit next. But when we start looking at transplantation of other organs, because we have the capability to mature pluripotent stem cells into cardiac cells, for heart transplant, or I don't know off the top of my head right now all of the different cell types we can do, but we can do a lot of them. So yeah, I do think that a healthy heart transplant is going to look different for one patient to the other, and we should account for variation. And even just, we need to think about sex, we need to think about age, we need to think about many different factors. There's going to be a lot going forward. But that being said, yes, we need more patients in this phase 1 clinical trial, and we need to continue to look at diabetes. I think it's the low-hanging fruit, and this is just step 1.
I think one more comment, Sean. It's mostly regarding this paper, and as you briefly touched on it, but as an organ, rather a disease, to try to cure diabetes is the first step to either CiPSCs or PSCs derived cell types. I think it's an excellent organ to work with. Reason being, it's easy to image, and just as this report came out as a 1-year report, I think it's quite easy to do this year on end without invasively changing patients' lifestyle, i.e. getting them to be an inpatient, operating on to probe and things along those lines. So I feel this will be an excellent start to what seems to be an organ production, in vitro organ production system that can be translated over to patients, and more so as this paper shows up here, for at least diabetes with low risk.
Yeah. Okay, so we need to wrap up this talk. We're coming to the end of our 15-minute discussion. If there was one question that you would spend an hour on after this discussion, what would your one question be? One question researching. And if you could say it quickly, because I need to do mine too.
I think I'll let you go first as I think it through, because there's a few.
I really want to know about the this difference between the transcriptional factor-based pluripotent stem cell and the chemically induced pluripotent stem cell, how dangerous would it be to do the transcriptional based pluripotent stem cell? Have they looked at that already? What is the rates of tumor development in mice and primates? That's what I'm going to spend my time on this week.
Excellent, Sean. And I think I've got a part answer to your question. And from my end, I think if there's a question, that would be, I think while MRI and ultrasound based imaging of tissue types is good, these have very low lateral and they have very low resolution in terms of going down to a single cell resolution. And specifically for cell types that are derived out of induced pluripotent or however kind of pluripotent stem cell derived into a unipotent cell state, I think there's a need to understand single cell level heterogeneity that exists within these derived cells, and how that could potentially in the future evolve to become either tumorous and or change its function type over a period of time, because the cell may not have attained full maturity at time of transplant. While it attains unipotent maturity, I think function maturity happens over a period of time, and once it's been introduced into the body, I think there is a change that evolves day on end as the body tries to accept this and it tries to integrate into the body.
Can you put it in the form of a question?
How would variations exist at single cell level in this kind of an implant over a period of time? And how would that impact its functionality and its interaction with the host organism? Because I will still say the tumor is alien because it went through a reprogramming process.
I like how you call it a tumor. Okay. Thank you guys for your time, and we'll see you next week.